Bismillah ar-Rahman ar-Rahim. We're starting discussion of a long case in this morning. Okay, we're starting.
My patient name is Ra Abdel Amir Jabur, 23 years old. She is a college student studying in Al-Musansariya College, studying French language. She is unmarried, single, living in Hayy Nidal Sa'doun, unknown blood group. Date of admission 12th of March 2017 and date of history taken 13th of March 2017. Chief complaint, vomiting and loose bowel motion for 1 week duration. History of present illness. The condition started before 1 month as a gradual onset of vomiting, which was after each meal, directly after the meal. A small amount began as a small amount, yellowish in color, containing only the food particles, not containing any blood, bitter in taste, and not associated with foul smell. It was recurrent several times per day. It associated with nausea all the time, abdominal pain which was centrally located, gradual in onset, colicky in nature, intermittent, lasts for a few minutes, relieved by vomiting, no specific aggravating factor. It also associated with loss of appetite. Then the later patient condition after 1 week, patient start also to complain from high body temperature associated with rigor, sweating, shivering, especially at night, lasts for 3 hours, relieved spontaneously and not without any medication. In last week, the patient start to complain from loose bowel motion 3 times per day, soft inconsistency, no change in its color, no mucus, no blood, also reduced in urine output, no pain in micturition, increased feeling of thirsty, no leg swelling, but generalized fatigue and generalized body weight loss. So patient admitted several times to a specific hospital here in Baghdad. Every time during her illness only received injection anti-emetings and discharged without doing any investigations. Then the patient yesterday, she was admitted also to a specific hospital here in Baghdad. At morning also received 2 injections, but the patient became sweating, shivering, so she discharged on her responsibility and came to our emergency department. In the emergency department here, blood urea, creatinine and complete blood and PCV was done for her, receiving 1 pint of normal saline. And
was anemic?
She was anemic after doing complete blood count and PCV. Her at the morning in the ward also she was sent for ESR, liver function test, renal function test, electrolyte, CT abdomen and chest CT. Began with her paracetamol tablet and was also received 3 normal saline. Patient is still vomiting. Even before her breakfast, she vomited 4 times. Only water in contain. Still rigor and shivering. This is regarding the history of a present illness. Systemic review, respiratory, she has a history of cough with sputum which was whitish in color, not associated with the blood. In sputum, no chest pain. This complaint, this only for before 6 months, and she did all the investigations regarding chest X-ray, which was normal, and also for TB bacilli also was normal. Other than this, regarding the musculoskeletal system, no joint pain, no restriction in movement, no weakness. Regarding nervous system, there is no headache, no fit, no blurring of vision. Regarding the skin, there is no skin rash. Regarding family history, patient has a family history positive of TB. Before 1 year, her brother was diagnosed and received treatment for TB for 6 months, and she said the symptoms of TB was improved after receiving his drugs. For social history, she is not a smoker, not alcoholic. For past medical, she is not diabetic, not asthma. She is not complaining from any chronic illness. For drug history, she does not use any drug for a long time regarding steroid or non-steroidal anti-inflammatory. On examination, she is young female lying supine on bed. She is uncomfortable. She is not dyspneic, not tachypneic. Her pulse rate was 90 beats per minute, regular rhythm and good volume.
There is no good volume.
Normal volume, not large. She respiratory rate was 16 cycle per minute, and temperature was 38.5 corrected axillary. And blood pressure, she was not a normal blood pressure, 12/8, 120/80 at the morning. She is cachexia, generalized body wasting, also masseter muscles atrophy and temporalis muscle wasting. She is pale, conjunctiva pale, not jaundice, the mucous membrane of the mouth pale, and dry tongue without any yellowish discoloration of the mucous membrane of the mouth. Regarding the neck, there is no visible mass in the central of, but only there is a large lymph node in the left cervical.
How is it large?
Here chart 5 by 3.
5 centimeters?
5 in width and height 3 cm. And it was there's by inspection overlying the skin normal. There is no erythema, no sinus, and on
the lymph node is what? Firm,
not
it
melted.
is firm. Painful or painless?
Painless and not movable, with not movable, and smooth surface,
and district
alone. This is
therefore, what are the characteristics of this lymph node?
This is for infection, not T.
I mean, a lymph node in the left cervical anterior triangle, which is painless and firm, and skin above it is normal. Is not matted.
Not TB.
It is against tuberculosis. Therefore,
Hodgkin.
it is a lymph node of Hodgkin disease. Farra dubbun. F firm. Rubbery. Dubbun district. Will be painless. Characteristic of Hodgkin disease. This young female, she is having either infection like TB because she had a contact to tuberculosis patient, her brother, or she have what? Hodgkin lymphoma, because it is nodal, lymph node in the cervical region. The best thing is to take this for biopsy, not to diagnose her on sputum, even it's positive. You might see Hodgkin disease with tuberculosis, and even though rarely you will find the lymph node with Hodgkin, caseating too is very rare. It's not 100% not caseating. Yes, sometimes caseating. And because she is ill, so ill, generally ill, probably the vomiting is due to her illnesses, acute illness or chronic illness, what you say. Therefore, to reach a diagnosis in this young female, you have to take a biopsy of that lymph node, because this is the only finding we have. No spleen.
No enlarged spleen, no enlarged.
Did she have axillary lymph node?
No, there is no axillary lymph node.
What about the breast of her?
Breast.
Every lady, she have an illness, especially in the chest, coughing. You have to examine the leg for DVT with pulmonary embolism, and you have to examine the breast for malignancy. Okay? Because she is young, is not that age of malignancy, but it is a must to examine the breast in every lady she presents with illness. This is a must. You will lose a lot of patients if you miss to examine the breast. You should palpate the breast. You should palpate the axilla to see whether if she have a Hodgkin disease, a Hodgkin lymphoma.
Generalized.
Therefore, this is most probably either tuberculosis. Is it? Against tuberculosis, usually tuberculosis, they do not have got a lymph node there unless it is bovine tuberculosis. And in Iraq, there is no bovine in tuberculosis after we sterilize the milk. It's very rare. Therefore, most probably this is a Hodgkin lymphoma, and this is the typical age because Hodgkin lymphoma is a bimodal, young age, elderly, while non-Hodgkin lymphoma is a elderly, 45 and more. Therefore, this is most probably a Hodgkin lymphoma. This is with the diagnosis of Hodgkin lymphoma because she is weight loss, she is febrile, she is vomiting, she lost appetite, is lost, etc. She have a loose stool. This is go with Hodgkin lymphoma and go with tuberculosis too. And the lymph node is go with what? With Hodgkin only. You know that Hodgkin is bimodal. Which country Hodgkin is unimodal?
In Japan, only
yes,
young
in
patients.
Japan it is unimodal, affecting single age. And Hodgkin, how many type of Hodgkin? Which is more serious Hodgkin? Which is more bad prognosis? Anybody? Lymphocyte depleted. Okay? If you found lymphocyte depleted in that tissue biopsy, this is usually serious. Prognosis is bad. While lymphocyte predominant or mixed, the prognosis is good. It can be treated. Okay. Therefore, probably this is a stage A, a stage 1 in Hodgkin, and because she is vomiting and have a symptom, because therefore it's stage 1B, not A. Because she have symptoms. Okay, you miss that and you didn't take a biopsy and been discharged without a biopsy. This is a fault. Even she have a sputum positive for tuberculosis, you should biopsy the lymph node because you might pick a Hodgkin and she had the tuberculosis too. And you say the chest X-ray negative. It's very rarely to get a positive tuberculosis sputum with a negative chest X-ray. Very, very rare. It means endobronchial tuberculosis inside the bronchus only. It doesn't reach to the tissue. And sometimes you get a TB bacilli, atypical TB bacilli positive in sputum. And this is also rare. Yes, tuberculosis is endemic in Iraq. We have nearly 4 to 6% of tuberculosis in Iraq, and even more. But you have to be sure that this is a tuberculosis patient before you starting the treatment. Okay? Because Hodgkin different treatment. This is if stage 1 Hodgkin, it's curable. Okay? Therefore, we miss that patient. And because she discharged herself,
Yes.
without a diagnosis, therefore we miss the diagnosis. And you start her on anti-tuberculosis treatment because of sputum positive. How come you start her on tuberculosis and with a negative chest X-ray? Where is the TB? Is the lymph node TB? Is it not? Usually is matted with sinuses. Skin over it is inflamed and involved. And usually is seen in those taking a raw milk from the cows, and you get bovine tuberculosis. But this young lady, she having a Hodgkin disease and dying. Red signs. It is misleading signs. I don't agree. Probably the diagnosis is wrong because sputum might mix from another patient. Yeah, probably she had tuberculosis too, but this is Hodgkin usually. Any question? Thank you very much.